can just cause a weak part of a blood vessel to burst, even if there's not an aneurysm there. When the blood spills out of this broken artery, that it doesn't flow where it's supposed to, and instead of supplying the brain in its normal fashion, it spills out, and then the damage is caused that way. So, how can we tell if a stroke is happening? It's important to know the main symptoms that can occur during a stroke. So, strokes generally are sudden. So, it's something that happens quite quickly, either instantaneously or it might get worse over a very short period of time, like a few minutes. So, one of the things is it could be sudden numbness. And the numbness is most often on one side, can involve face, arm, leg. Also, it can involve weakness, so strength. By numbness, we mean sensation, our ability to feel things. And by weakness, we mean our ability to move our hand or our leg. And these come on suddenly. Sometimes the part of our brain that's involved in forming words or understanding words is affected by the stroke. And a person can have a sudden loss of the ability to get the words out right or the ability to understand what a person is saying, and they may appear to be confused. They can also have slurred speech. And as a neurologist, we think of this a little differently between slurred speech and like not being able to get the word out we want, but both can be symptoms of a stroke. Sometimes stroke can affect the vision. Sometimes people might not even notice this because of the nature of how the vision loss occurs, but a person might not be able to see all the way to the left or all the way to the right because of a stroke affecting the vision part of the brain. If stroke affects the coordination part of the brain, a person can have difficulty with the controlled movements of their arm or leg and can feel like they've got this clumsiness or a loss of coordination. Oftentimes, a bleeding stroke is accompanied by a headache. And this is something that people will say is the most severe headache of their life. It can just come on suddenly, describe it like a thunderclap, and it's just very intense and severe. And it's important to know that that could be the sign of a bleeding kind of stroke or a hemorrhagic stroke. Strokes can occur during sleep. So even if you go to bed feeling pretty well, sometimes people wake up and find that they have the symptoms of the stroke because the stroke happened through the night. And if you ever have a symptom of the stroke where you have one of the things like we just talked about that came on suddenly, you woke up with it, you want to seek medical attention because there are things that can be done quickly to help prevent more permanent damage from the stroke. So a few stroke myths to go over, some things that people might think that are just not true. One is that a stroke occurs in the heart. That's not correct. Strokes are caused by reduced blood flow to the brain. Another is that a stroke is going to hurt. And really, most of the time when a person has the ischemic kind of stroke, that is the stroke that is caused by a clot blocking up blood flow, it's not painful. The bleeding ones are painful most often. So you're thinking, well, what can I do to try to not have a stroke? Well, one of the things to do is exercise. When we exercise, we generally have better blood flow. We have our arteries more open. We have also often a lower blood pressure, which is a cause of stroke that we'll talk about later. So if you get 2.5 hours of exercise in a week, then that's good. You want to eat a healthy, balanced diet. Having high cholesterol can put you at risk for stroke. Smoking is a major preventable stroke risk factor. Smokers have a higher chance of stroke because of plaque formation that occurs in the arteries and damage that is done to the arteries. So we want to not have anybody smoke. Alcohol in moderation, high levels of alcohol can cause stroke if we're drinking too heavily. Make sure you visit your physician regularly. Your physician can diagnose things that put you at risk for stroke. Certain medical problems, which we'll talk about in a little bit, can put you at risk for stroke. And sometimes you don't know if you've got these unless you look for them. And we've definitely seen people that have come in with a stroke and not realized that all along they had high blood pressure or they had diabetes because they hadn't had that checked for. So keep your cholesterol low through that diet that we talked about. Keep your blood sugar normal, as diabetes is a major cause of increased stroke risk. And then once you're on the medications that you need to be on, that your doctor has prescribed for your underlying conditions, then you want to make sure you take them regularly as prescribed. Missing doses leads to inadequate control of these underlying problems. So what are our current blood pressure guidelines? Well, we'd like to get our blood pressure, typically the top number, that's what we call the systolic blood pressure, less than 120, and the lower number, the diastolic blood pressure, less than 80 for optimal blood pressure. And controlling blood pressure is the number one most important way to prevent stroke. If you've got a number of different things that are wrong, the thing that can reduce your stroke risk the most is getting that blood pressure under control. When it comes to stroke, it's okay to overreact. If you're at home and you're not sure if you're having a stroke, don't wait. You don't have to figure it out. We'll figure it out. Come to the emergency room. This is not something that you were trained in, and you don't have to decide if it's a stroke or not. If you think it might be, come. We will figure it out, because we want to treat you quickly if that is indeed what is happening. And if it's not a stroke, then okay, well, we ruled out something sinister, but it's better to come and have it not be one than to not come and have a stroke at home. Don't wait to see if the symptoms go away. There's a lot of times we hear this, where a person suddenly has a weak arm or leg and they think, well, maybe if I just wait a little bit, this will get better. Don't do that. We can fix it, but there's a time limit to some of the treatments that we do in the emergency department, and they work better if you get there faster. So get to the emergency department as quickly as you can if you think you might be having a stroke. Once again, let's review the symptoms of stroke. You can think of the words be fast. So B for balance. Sudden loss of balance can be a sign of a stroke. E for eyes. Sudden loss of vision or sudden double vision can be the sign of a stroke. F for face. If you see a person with a facial droop, like the corner of their mouth kind of droops down, they might have slurred speech with that. A for arm or leg weakness. S for speech. If a person has trouble forming the words or just trouble coming up with the words or even trouble understanding the words, then that can be a sign of a stroke. And T is time. Remember, you want to get there fast as you can. Treatments for the new strokes work best if they're done quickly. So why should I call 911 right away? Well, there's a medication called TPA, and this came out in 1996. It's been around a while, and it works better the faster you get it. Not everyone's a candidate for it, and we don't use it for the bleeding type of strokes because it breaks up blood clots. But once the stroke starts, you've got 4.5 hours that we can give the TPA. And if it's longer than that, then it's not been shown to have the benefit. So you've got to get there fast. So what happens if a person's given TPA? Well, we find that, sometimes you can see it work very quickly and it breaks the clot up and the symptoms get better. But that's not always the case. Sometimes it takes longer to see the effects of the TPA. But we do know that when patients are given TPA, if you take a look at them and compare them to patients who were not given TPA after 3 months, the ones who were given the TPA do better. So we've talked about strokes. Another thing you might hear about that is similar to a stroke is a TIA. TIA stands for transient ischemic attack. So the T, transient, which means the symptoms come, but then they go away. And generally they go away in 20 minutes. Again, don't wait 20 minutes to find out if they're going to go away. Come to the ER. If they go away, great. But if they don't, then you're there faster and we can get you treatment faster. The I is for ischemic. So we talked about 2 different kinds of stroke, and the ischemic type is the kind with a clot, and then attack. You can think of it like a heart attack, and then we just put that word in there. So TIA, transient ischemic attack. They have the same symptoms as strokes. They just go away after a short period of time. If you have a TIA and it goes away, it does mean that something is wrong. Something is causing you to have a higher risk of stroke. So you still need evaluated, even if your symptoms get better. And we'll talk about the things later that we're going to do to evaluate that. 40% of people who have a TIA will end up going on to have a stroke. So just because everything got better doesn't mean nothing needs done. You still need to come in and see what is it at the cause. And you need to do it quickly because it's more likely after a TIA to have a stroke in the short period of time, like in the first couple of weeks after that TIA. All right, so what are some of the risk factors for stroke? High blood pressure, talked about this. Number 1, preventable risk factor for stroke. Number 2, here we have diabetes. Diabetes is a lot of things that hurt your body. But one of the things that it does is damage the blood vessel walls. And those damaged blood vessels can cause narrowing, and that narrowing can then lead to a complete blockage of blood flow through the arteries. So diabetes puts you at risk for stroke. High cholesterol, cholesterol can form plaques or blockages in your arteries, and those can lead to stroke. So we do not want to have high cholesterol. If a person has coronary artery disease, so that's heart artery disease, that means that they might also have disease in the arteries of the brain. Usually what's affecting the artery in the heart is not just limited to the arteries in the heart. It could be affecting the arteries in the brain as well. So if you find heart or artery disease there, it's very likely that something's going on in other parts of your body as well. Carotid artery disease. These are the main arteries that go up to the brain, and they can get narrow. And when they get narrow, sometimes they form a little plaque or clot there that then flies off and sails up into the brain, and then that can lead to a stroke. Heart failure. If a person's heart is not pumping in the normal way, clots can form there, and those clots can dislodge out of the heart and flow up to the brain and cause a stroke there. And of course, if you've had a stroke before, or if you've had a TIA, then that means you're at risk for having something like that happen again. So we're going to do different things. We're going to treat things differently if a person has a stroke or TIA, maybe be more aggressive with cholesterol treatment. And then peripheral vascular disease. So just like if you've got disease in the arteries in your heart, if you have disease in the arteries in your legs, then again, it's probably not just your legs. You very well could have changes in the arteries up in your brain. Atrial fibrillation. This is an abnormal heart rhythm where the heart beats irregularly. And when it beats irregularly in atrial fibrillation, clots can form there, and those clots can then dislodge and sail up to the brain, causing a stroke. Here's a little picture. You can see how the heart down there at the bottom is connected to the carotid artery, which we talked about can get blocked up and also cause stroke. And then, of course, blood flows all the way up to the brain. So if there's a clot that forms anywhere along there, or a piece of plaque that is there and dislodges anywhere along that path, it can sail up to the brain, block up an artery up there, and cause a stroke to happen. So some other stroke risk factors. Hang on. Is my screen being shared okay? Someone, oops.
Yep, we can see your screen, Dr. Stocker.
Okay, thanks. Sorry, I just saw a message that I turned off. I didn't see it. Let me go back. Okay, some other stroke risk factors. So if your family has a history of stroke, it puts you at high risk for stroke. Sleep apnea. Some people stop breathing at night, and when they do, this causes changes in their body to have an increased risk of stroke. So if a person has sleep apnea, and you might know about this because you see them stop breathing in the middle of the night, they snore, and then they choke, and they wake themselves up, that's a risk factor of stroke. Sleep apnea needs evaluated and treated. And smoking is again a risk for stroke. Drinking too much alcohol and certain drugs can lead to stroke as well. Cocaine, for example, can cause spasms in the arteries in the brain, and then that can lead to stroke. The older we get, the higher chance we have of stroke. So we're all getting older. It's just important to make sure that we're looking at all the other risk factors that are manageable or modifiable, because you can't turn back the clock. And then certain inherited blood clotting disorders can lead to stroke. So some things you can't control. You can't control what's happened in the past. So if you had a stroke or TIA, that's happened. You just got to do your best going forward. You can't control your genetics, and you can't control your age. So, but what can you do? You can take all the medication that is prescribed. You can exercise, move your body, keep that blood flowing, and reduce your risk of stroke. Have an appropriate diet. Don't smoke. Control your chronic medical problems such as high blood pressure and diabetes. And then if you've been diagnosed with sleep apnea, make sure that that's appropriately treated and you wear your CPAP and BiPAP. Okay, well, let's say that unfortunately we've done all these things and you still show up in the ER and you're having a stroke or TIA. What are we gonna do? Well, we mentioned first, if you're a candidate for the blood clot treatment, TPA and you get there within the first 4.5 hours, or fast enough that we can give it within the first 4.5 hours, we can give TPA in the emergency department to try and break up that blood clot and improve your outcome. Another thing that can be done immediately is we can send you to a neurointerventionalist. And what they do is they go in with a catheter and try and pull the blood clot out. And there's a longer window of time that this can be done. But the clot has to be in a certain place. It has to be kind of close and big to like the major arteries. If it's a small clot and it's far away from the main arteries, then you can't do that. So after that, you're going to come into the hospital. If you have a stroke or TIA, we're going to do some evaluation. We'll get an MRI scan of the brain, and that will show us exactly where the stroke is and how big it is. We'll check some things to see if they need fixed. We'll check your cholesterol. After a person has a stroke, our goal numbers for the LDL cholesterol, the bad cholesterol, as people think of it, become lower. So what your primary care doctor might have felt was an okay cholesterol before our stroke is not necessarily the same number that it might be after a stroke. So a lot of times we'll just really try and get more aggressive and lower the cholesterol lower to try and reduce the future stroke. We'll check an ultrasound of the arteries in your neck, the carotid arteries, and do an ultrasound of your heart. We're looking there for blockages in the neck, and we're looking for blood clots in the heart. And then to check for atrial fibrillation or other abnormal heart rhythms, we'll potentially use a 30-day heart monitor where after you leave the hospital, a heart monitor will come to you, or you'll be set up as you go, and then you'll wear that for 30 days. And then the cardiologist will look at that and see if there is any abnormal heart rhythm that needs treated with like a blood thinner for that. So after we've done this testing, what might we do? What might we prescribe? Well, generally, immediately after a stroke or TIA, you're going to be treated with both aspirin and clopidogrel, which is the generic name for Plavix, for 3 weeks, because it's been shown that in the first 3 weeks is when the highest risk of recurrent stroke or TIA is. And then after that, you'll be on one or the other, most likely, because after that, being on both of them just causes more bruising and bleeding and doesn't really help more than just being on one of them. Another possibility is a person could be treated with anticoagulation. This medicine previously was just Coumadin with a generic name warfarin, but also now there's newer kinds of anticoagulation, and medicines that go by the name Eliquis, Pradaxa, and Xarelto might be used if a person needs anticoagulation. We'll put you on one of the statin medications. This is a class of cholesterol-lowering medications to lower the LDL cholesterol if it's too high. And then if a person has a major blockage in one of the carotid arteries, then we'll contact a vascular surgeon for evaluation, and a person might need to have a surgery or a stent put in to open that artery up. So some key points. We want to be fast. The best treatment for stroke occurs in the first 4.5 hours. So get to the emergency department if you think you're having a stroke or TIA. Call 911 right away. Get the squad out there. Have them bring you into the hospital. And then remember and know the stroke risk factors that you have and do your best to manage them, lower them, keep them under control. Quit smoking and make sure your diet is appropriate for you. All right, that ends my prepared slides, and I'm happy to take whatever questions we've got.
Thank you so much, Dr. Stocker. Yes, let's go ahead and move on to questions. So all of you participants, please feel free to unmute yourselves so that you can ask Dr. Stocker any questions you would like. If you're not comfortable with physically asking questions, there's a chat feature on your screen. Down at the very bottom, you'll see the chat, and there's a little dialogue bubble right there. Feel free to type in your question. It'll go directly to me, and I can get that to Dr. Stocker as well. So please feel free to do whatever's comfortable so that you can get your questions answered. We do have a couple of questions that were submitted ahead of time. And the first one, Dr. Stocker, do TIAs often lead to stroke?
So TIAs definitely point to the fact that something is wrong. So they can lead to stroke. They don't always lead to stroke, but they're a sign that something has happened that has caused a blood clot to form in your body, and your body sort of took care of it itself. You know, the blood clot resolved on its own without causing any damage. But something caused that blood clot to be there in the first place. So we need to investigate. We need to find out what that is. We need to take a look at your medications and decide if something needs changed. So it definitely always needs evaluated if a person has a TIA.
Perfect. All right. The second question that was submitted ahead of time, does a history of Bell's palsy increase your risk for a stroke? And we may want to also, a lot of people might not be familiar with Bell's palsy, so maybe talk
Sure.
about what that is and if it does increase it.
Absolutely. So what Bell's palsy is when there is an injury to the facial nerve and that causes weakness. So Bell's palsy, if a person has that and you were to see them, you might see weakness in their forehead. They might not be able to raise their forehead up. They might not be able to close their eye all the way. And then they'd have a facial kind of droop and they wouldn't be able to move one side of their face. That's generally caused by a virus. So a virus gets in somehow through the sinuses or some such way and infects the facial nerve on one side of the face, and that causes swelling, and that swelling is what causes the nerve injury that causes Bell's palsy. 19 out of 20 times, people with Bell's palsy will recover completely. Sometimes it does result in lasting facial weakness. This does not put a person at increased risk for stroke. They're separate things. Bell's palsy is a virus. It does make you weak, but it doesn't make you weak in the same way as stroke. Stroke is caused by not enough blood flow. So they're different.
Perfect. All right, we had our first live question come in, so thank you so much. Brain bleeds, Dr. Stalker. Could you talk a little bit about treatment and prognosis for brain bleeds?
Sure. So brain bleeds come in all sorts of different levels of severity. So they might come from an aneurysm rupture, they might come from a weak artery, and they might come from another kind of vessel malformation, and they might come from something called amyloid angiopathy, which is like changes in the brain that make it more susceptible to bleeding. In general, the prognosis for a bleed depends on the size of the bleed. So the larger the size of the bleed, the more area of the brain it is damaged, and the more likely that there is going to be lasting problems. For very significant brain bleeds, there might be permanent problems, or some are actually not survivable. Some ruptured aneurysms are not survivable. So what do we do if a person has a brain bleed? Well, sometimes you do nothing. So if a brain bleed is small, and especially if it's deep in the brain, you can't get that out of there. You can think of the brain as being kind of like a sponge in the brain, and if you had blood in a sponge, you wouldn't be able to get it out of the sponge. I guess you could wring the sponge, but we're not going to wring the brain. So it's just kind of in there, and you just have to wait for it to go away. And it goes away on its own over time. Just like if you have a bruise in your skin, you'll see it kind of change color and eventually go away. Same thing can happen with a brain bleed. If a brain bleed is larger and if it's on the surface, then the surgeons will sometimes try and drain that blood off of the surface of the brain. So that involves going to surgery. They, make an incision in the scalp and then cut through the skull and drain the blood out. Sometimes the blood will go into the center of the brain in what's called the ventricles. And this is an area where the spinal fluid is normally in the center of the brain. And if the blood gets into there, sometimes they'll do a drain and drain it out of there. So the answer is everything from nothing to surgery to drain the blood, and it completely depends on the location of the bleeding, and it completely depends on the size of the bleeding. Similarly, prognosis is the same. It depends on the size of the bleed and also the location of the bleeding. Did I get everything out of that multi-part question? I think I did.
I think so.
Okay.
Another person had asked, you talked a little bit about like LDL, the bad cholesterol.
Right.
For those who might not understand the difference between LDL and HDL, and should you focus on your overall cholesterol number or look more specifically at LDL versus HDL?
Yeah, so I think you just sort of, you have to kind of look at that. If you're looking at your total cholesterol and your overall health, you got to look at them all. So the total cholesterol is made up of triglycerides, HDL, and LDL. And we sort of think of the HDL as being the good cholesterol and the LDL as being the bad cholesterol. And that's sort of a simplified way of looking at it, but I think that's a fine way to look at it. The HDL actually gets higher if you exercise. So you can raise your HDLs with exercise. And you shouldn't look at that in a negative way, I suppose. So if your total cholesterol is higher because your HDLs are high, then that might not necessarily be a bad thing. For the LDLs, specifically with stroke, the current guidelines, we want to get the LDL below 70. The guidelines have changed over time. At one point it's below 100. Now we shoot for below 70. That is lower than you would normally have your primary care physician shooting for your LDLs. But once a stroke is there, that's a sign that we need to be a little more aggressive. And so we shoot for a lower number. Total cholesterol is not really something we look at in stroke, and we don't base our treatment on total cholesterol in stroke. But for other disease states, like maybe heart disease, your primary care physician might have look at that as a goal thing too. I will say, most of the time, if the total cholesterol is too high, it's because the LDLs are too high. It's not because the HDLs are too high.
Perfect. A follow-up question, when you were talking about like brain bleeds and treatments, does age change prognosis and survival rates when it comes to stroke or brain bleeds, like the health of the arteries? Do they change with age, or does age really not matter?
Age definitely matters. So as we get older, it's harder to recover from the same kind of things. So, and there's both like a chronological age and then, a biological age. So some people, are a young 70 and some people are an old 70, or pick any number in there and put it. So your overall level of fitness certainly matters. But, as time ticks on, it's just harder and harder for our bodies to recover from the same sort of things that they might have been able to more easily recover from 10 years ago. So age matters. Not everyone the same age is exactly the same, but it definitely matters.
Perfect. All right, Christine has another question. Dr. Stocker, what are triglycerides? We talked a little about HDL being good, LDL being bad. What exactly are the triglycerides?
And they're another kind of cholesterol, and you can kind of think of them as bad, and they can be high. And so when you get like a cholesterol panel, the triglycerides are another thing in there that you don't want to be high. And if they are high, probably your total cholesterol is high too. And it's just a component of the total cholesterol.
All right, perfect. That's all we've received for questions through chat. Is there anybody on the program that would like to physically ask a question? Oh, you're welcome, Christine. She said, thank you, Dr. Stocker.
Oh, my pleasure.
Is there anything anybody else would like to ask before we wrap things up with Dr. Stocker? I don't see anything else. Dr. Stocker, is there anything else you would like to add, or maybe questions that didn't get asked that you're normally asked, or anything like that?
No, I would just like to say thanks to everyone for coming and listening and learning about stroke. And don't let it stop here. Educate your family members who maybe didn't hear this, and teach them too. We want everybody in the community to know as much as possible about stroke, understand the importance of seeking treatment rapidly. I mean, really, that's the main thing. And just remember what I said before, like, you don't have to decide if it's a stroke or not. We'll help you with that. Like, if you're worried that it's a stroke, come see us, come to the emergency room, get attention. We'll help.
All right. Well, thank you so much for being with us today, Dr. Stocker. We really appreciate your time. I know your schedule is so busy, being a neurologist and a medical director here, at Mercy Hospital. So we just really appreciate you taking the time with us this morning. For our listeners, if you're interested in our next community education program next Wednesday, April the 28th, Julie Dominic, who is a certified driving instructor and coordinator of our driver rehab program here at Mercy, she'll be on talking about safe driving and how to stay fit to drive. So hopefully you guys will join us next week. And again, thank you, Dr. Stocker, and we hope everybody has a great weekend. Thank you.
My pleasure. Thanks, everyone. Have a great weekend.